So now I'm going to welcome Diane, who's spoken before, one of our roadshows, but Diane's got a case study for us. So over to you, Diane.
Hello, everybody, and thank you very much for asking me to come along today. Really interesting, some interesting discussions, and also in the chat. And my case study today is actually somebody who's an older adult. Though I would echo what previous people have said, is we are seeing increasing numbers of people coming through, young people, where we're having to look really carefully at home environments. But I'm an OT working in a mental health learning disability team. And until about 5 or 6 years ago, I had very little experience of housing at all. So in some ways, this is brilliant timing for me and some of my colleagues, because it's something we are increasingly looking at, as I think that statistic was really shocking, wasn't it? Was it 48% of discharges are delayed because of housing issues, which is truly terrible, really. But I wanted to talk about a gentleman I've been working with who's in his 70s, actually, with a learning disability, autism, and a diagnosis of pica. And I don't know if everybody knows that, but pica is basically the ingestion of non-edible items. And he's been living in his own ground floor flat, which is part of a supported living service, for over 27 years. But with very specialised support, and they're a service that are almost attached to our trust. So there's good access to a range of other health professionals as part of that. And unfortunately, I nearly left then. He had a period last year of being in hospital, in a mainstream hospital with pneumonia for I think he was in hospital about over 6 months in the end, because it was found on X-ray that he wasn't recovering in the community to antibiotics. And when they did the X-ray, they realised he had actually ingested, I think it was a 5-pence piece that was lodged in his lungs. And some of the other things that we were seeing was just increased frailty, becoming older, finding just everyday tasks more difficult, needing more support. His mobility was decreasing, and just basic functional skills, we were seeing a decline, really. And when he was in hospital, there was a lot of discussion at that time about whether or not this was a time, mainly social services were looking at this, whether or not he should be returning to his own flat, or whether or not it was time to look at him moving to more residential care, really, where there would be more staff around, possibly somewhere with nursing support. And one of the things we looked at, we developed a tool locally some time ago called the Safe Home Environment Assessment. And we looked at this in terms of what were the risks about him going home to his own home, where he'd been very happy, very settled, very few incidents actually in the latter few years, and where he had really skilled support. And I think one of the earlier speakers mentioned, Coral might have been, that we have to look at, it's not just always sometimes the physical environment. If we'd have gone to the residential care option, it could have been, we could have made, more, we could have had a slightly more easier to manage physical environment. But what we would have lost was the skilled staff who were around him. And that really constituted what we thought was like a capable environment for this gentleman. And he had staff working with me. He didn't actually have family. Most of his family's had died or weren't around anymore, but some of the staff team had known him over 20 years, and they were really brilliant actually at advocating and knowing him really well. So when we looked at the risks within his environment, they were brilliant in actually being able to very quickly identify what we could do within his existing flat to make it more to future-proof it, really. And because it was one of those big Victorian houses that was carved up many years ago, it was looking very tired and was no longer meeting his needs. And part of that was because I think he had very poor tolerance of people going into his environment. Even doing things like decorating was hugely traumatic for him, actually. But following admission to hospital, we really looked very closely at what could we do within his actual flat to make it a safer place for him to return to. rather than looking at him having a really, really traumatic transition to a completely new setting, but with staff who wouldn't know him as well as his existing staff team did. And as you can see, this is just a picture of his bathroom at the moment. One of the, it does look very tired, doesn't it? So he had a perpetual issue of tearing off toilet seats, and the staff team had tried loads and loads of quite innovative things to kind of manage this behaviour. But one of the real concerns was, one, functionally, it wasn't very nice him sitting on this toilet without a toilet seat. But every time they replaced it, it got pulled off. And there was a real concern around the screws and the risk of him ingesting these like bits of the toilet seat, because I think they were found he also had bits of plastic in his stomach when he was in hospital. So one of the things we did was, this has come about at really brilliant timing for us, because we were looking at how could we do these adaptations, and fortunately have very, very good local housing OTs who have tons of expertise around DFGs, who we managed to speak to, and together, actually, and I think that's true, it's about the collaboration, isn't it, of us really knowing him really well, but them really understanding the processes. And this isn't a before and after. This is kind of what we're aiming for. We've gone for an integral toilet, similar to what you might actually see in a hospital, because it's referred to as ligature resistant. But the idea is an integral one, all-in-one system. So there's nothing to pull off. There's no bits. There's no screws. And then looking very much at a very standard adaptation, actually, in terms of DFGs, looking at just putting in a level access shower, but also this bathroom has no windows. It's very kind of dark. It's in the middle of the flat, really. It's looking at, well, what can we do around the sensory aspects of this to make it a nicer environment for him, so that we can actually support his independence within his own home for much longer, and also reduce the need for the staff having to go and support him, because at the moment he's really struggling to get in and out of the bath. And I'd already tried before his admission we've done the bath boards, we did the bath seat, none of those he really tolerated. But when he was in hospital, he actually managed to tolerate the shower. So we kind of thought, well, that seems to be the next logical step really for us. And this is kind of an example of us working more collaboratively, sharing our skills and us understanding some of the sensory elements of behaviour, having access obviously to the whole of the MDT, which is obviously a massive advantage, but then working with local experts like our housing OTs who have been brilliant, because they came up with loads of things we hadn't even considered, such as how we're going to manage the work, how we're going to do this, how long would the work likely take, how to facilitate people going in and getting the quotes done. There was a whole load of planning we've had to do around even where's he going to be living while we do this work. And they were really good because they'd had all their skills and experience of having done this many, many times before and knowing kind of what can go wrong. So that's what we kind of did. We looked at the DFG as being a really good funding opportunity, because we weren't even sure how we were going to even get the funds to do this. It's enabled him to live in his own home for a longer period with all those familiar and skills support, future-proofing it so we can actually think about, as his skills are deteriorating, we've been able to kind of think about making sure we can maintain his independence for as long as possible. And also reducing the risk of another really lengthy and traumatic hospital admission by making sure that we've almost gone through and thought of every possible risk we can see in the environment in terms like kitchen. We've had to put in restrictions, but that's going through court of protection in terms of looking at what the least restrictive options are. But some that we've had to do, like locking fridges actually, which was something we hadn't had to do before. And also it's been a really great opportunity to work more collaboratively with our local housing OTs. And that's been helpful in terms of kind of looking at some of the cases that they're getting through, which are younger people, which we're now thinking, how do we start to work with people when they're 19, but we've actually had a few cases recently where we've gone down a bit to kind of do a bit of preventative work where we've come across people who are really struggling with, their families are really struggling, and working more collaboratively as a broader system, actually, which seems like totally sensible. And like somebody said, it saves so much time and distress to everybody if we can be a bit more pragmatic about this sometimes. And we've learnt lots of skills that we didn't have as OTs working in learning disabilities in terms of what's possible. The community of practice, I would echo, has been brilliant. And I think it is that idea that we can all bring our different skills and expertise and share that in a kind of open way in terms of what works and what doesn't. And I think that was pretty much all what I wanted to say. But the Good Practice Guide is a really brilliant initiative in terms of kind of helping people work through that process. And so I look forward to reading it in more detail as well. So that's all I was going to say, really. It's a very short case study. So.
Great, thank you, Dan. But I think kind of really useful for bringing out some of the points that we've kind of already discussed and kind of touched on this afternoon, kind of given a bit of flavour in what it means in real life.